Hi, everyone. My name is Katie Gillespie, and I work with the University of Wisconsin-Madison Prevention Research Center as the Deputy Director.
My name is Ellie, Knoll, and I am a graduate student assistant with the Prevention Research Center.
Hi, everyone. I'm Hannah Gjertson, and I am the Maternal Mortality Review Coordinator at the Wisconsin Department of Health Services.
And I'm Emily Morian-Lozano, and I am the Maternal Mortality Review Epidemiologist with the Wisconsin Department of Health Services.
We're going to talk with you today about a project that we did collaboratively called Improving Linkages to Address Opioid Use Disorder Among Pregnant and Postpartum Women. Our objectives for this session is to explain the purpose and background of the Wisconsin Maternal Mortality Review, to demonstrate the value of using rapid qualitative analysis for timely application of review findings, and to identify the value of engaging community partners in the qualitative analysis. So for this project, the University of Wisconsin-Madison Prevention Research provided an analysis and design of a report that focused on the qualitative data related to the overdose deaths from the Wisconsin Maternal Mortality Review Program within the Department of Health Services Division of Public Health. Our steps to the project were to gather community partner input on critical factors and recommended actions, to draft report of team findings on the community input, to present the report to the Community Advisory Board and the MMR team for feedback. Oops. Yeah. To revise the report based on their feedback, and to disseminate the report broadly.
I will give a little bit of background on maternal mortality reviews, if you're not familiar with these. So currently, almost all US states and some large cities throughout the country have some version of a maternal mortality review team where the deaths of pregnant and postpartum people are reviewed. Nationwide, maternal mortality review teams collect and review case level information about deaths that occur either during or within 1 year of pregnancy. And this is a timeframe that is recommended by the CDC, but may vary by different jurisdictions. So there is national advice for how to conduct MMRs, but states do them a little bit differently. So when we're talking about maternal mortality review in Wisconsin, we've had a long history here dating back to about the 1950s. But today it's a joint effort between the Wisconsin Division of Public Health and the Wisconsin ACOG. So recently, Wisconsin was awarded some additional federal funding from the CDC called the ERASE grant, which is the Enhancing Reviews and Surveillance to Eliminate Maternal Mortality. And this was a 5-year grant and cooperative agreement between the Wisconsin Department of Health Services and the CDC that allowed us to kind of expand the maternal mortality efforts in the state and kind of basically promote other reports and new findings that the team was seeing in our reviews. We also had some additional funding that was specifically for overdose cases, which I'll talk about in the next slide. But that is also what kind of the foundation of this project was based on. In terms of the team itself in Wisconsin, we have a wide range of people that are on our team, including positions such as obstetricians, maternal fetal medicine specialists, midwives, forensic pathologists. We have a perinatal psychiatrist. There's a large number of people that participate from throughout the state that have some sort of background and professional affiliation with maternal health throughout Wisconsin. So the team meets about 4 to 6 times per year to review de-identified cases of all deaths that have occurred to Wisconsin residents. So, and this team is going to then work together to kind of make determinations about questions like if the death was related to the pregnancy or not, whether the death was preventable, and then to work on generating recommendations that could be implemented to prevent these future deaths. And so our focus here is on the public health framework of prevention. And the main output of this team is recommendations on changes in systems and practice that would result in the prevention of future deaths. Next slide. And so with this project, like I said, we do have a focus on substance use disorder. And this was a result of a 9-month grant from the CDC Foundation that wanted to address pregnancy-associated overdose deaths. This was really important in Wisconsin because we know that about 1 in 3 of all pregnancy-associated deaths in Wisconsin were due to overdose from 2016 to 2019. And we know that about 85% of those were accidents. And when I say accident here, I'm talking about the intent, meaning they were unintentional, because we do have some that were intentional, but you can see here the large majority of them were accidents. And so we know there's a lot of room for prevention there.
So now I'm just going to give you some highlights of some of the data that we included in this report. Next slide, thanks. So this first graphic, you can see we had 143 pregnancy-associated deaths during the years 2016 to 2019. This means all deaths that occurred during or within 1 year of the end of pregnancy, regardless of whether or not they were related to pregnancy. So in this graphic, you can see that the deaths are split out by overdose deaths or non-overdose deaths. So half of all 2016 to 2019 pregnancy-associated overdose deaths occurred 6 to 12 months after pregnancy, compared to pregnancy-associated non-overdose deaths, where only about 25% of those occurred during the same period. So these overdose deaths are generally occurring at a later time in the postpartum period compared to those deaths that were not due to overdose. Next slide, please. Looking at some of the disparities, we all probably know that there are the disparities that exist within maternal mortality. And here you can kind of see a breakdown between pregnancy-associated overdose deaths, non-overdose, and then looking at births. So if you specifically look at the highlighted category in the chart, you'll see the non-Hispanic, Black, or African-American moms. You can see that they make up only about 12% of pregnancy-associated overdose deaths. However, they make up 34%, or about 1/3 of pregnancy-associated non-overdose deaths. So sometimes people say, well, the non-Hispanic white moms are actually overrepresented in the overdose deaths. And you'll hear that often by other reports. But really, if you look at this compared to births, non-Hispanic Black moms are really overrepresented in these non-overdose deaths. So 34% of these deaths are to non-Hispanic Black moms, while only 10% of births are non-Hispanic Black. And then if you look at non-Hispanic white moms, you'll see that they make up about 72% of births and about 73% of pregnancy-associated overdose deaths. So those numbers are actually very comparable. They kind of make up the same proportion of pregnancy-associated overdose deaths compared to the proportion of births. Next slide, please. And then finally, just some information about the reviewed cases. So of these 2016 to 2019 pregnancy-associated overdose deaths, 13 of those cases had been reviewed at the time of this report. And for all pregnancy-related overdose deaths, that means that the maternal mortality review team determined that they were related to pregnancy. The underlying cause of death selected most often was the code for other psychiatric conditions, and that was about 86% of those deaths. The team also determined that 100% of overdose deaths reviewed were preventable, and about half of them were pregnancy related. And then of the 13 reviewed overdose cases, just over half were determined to be pregnancy related by the MMRT. Mental health conditions and substance use disorder contributed to nearly every reviewed overdose death. So you can see here 92% of the cases, the team said that mental health conditions other than substance use disorder did or probably did contribute to the death, and then 92% as well for substance use disorder. Next slide.
So now we're going to talk about a subset of cases that where we looked at the qualitative information to do this analysis. And our key questions were, what are the critical factors contributing to maternal deaths in Wisconsin? And what are the recommendations to mitigating the critical factors? Specifically, who should do what, when? So for our analysis, we used the rapid qualitative analysis method. It's often used in health systems for quality improvement efforts. It allows for immediate application of qualitative data from collection methods such as surveys, interviews, and case studies. One of the goals for this project included identifying a process to use the maternal mortality review qualitative data going forward. We're suggesting that RQA can be an efficient process for this. It basically organizes qualitative data using simple software like Excel and Microsoft Word. And you can organize the data in the same format in tables to build data reduction tables. The tables go through multiple iterations where the data is narrowed to arrive at a streamlined list of results to use in presentations, papers, and reports. After formatting the data, the team should determine their research questions that will be used to guide the reduction process. In other words, you focus on the content that is of primary interest. For this analysis, we have had 3 different analysts to arrive at the final tables, and our maternal mortality review team and our community advisory board from the UW Prevention Research Center contributed to the input. Our rigor for our QA technique is achieved by mapping the information in each data table phase between the individual team members and across the different data table phases. Going forward, if there is a decision to repeat the process, the recommendation would be to have a minimum of 3 people involved and 3 to 5 iteration phases for the data. So the steps for RQA include as a recap, formatting and organizing the data, reducing the data, analyzing the data, and then draft your product deliverables. So as we mentioned, we did this with our community advisory board and the maternal mortality review team. So we started with separating the data for the critical factors and recommendations for the 13 cases from 2016 through 2017. We initially synthesized the critical factors and recommendations separately in Excel. We identified notes and codes that allowed us to merge the critical factors and recommendations. And we went through 3 iterations of the merging process of grouping critical factors and pairing them with the recommendations. We shared the final iteration with the subgroup of the review team members, and the critical factors represented the following themes and sub-themes. And we didn't necessarily have recommendations for all of the themes that emerged from the critical factors. So the themes included access to care, support, policy, bias, and discrimination. And under those sub-themes included prenatal and care and family planning that represented issues with missing or unavailable care, mistimed and delayed care, substance use that included the geographic existence of care, provider and facility coordinating the care, provision of rescue medications relates to services either not being available or providers not facilitating access. And it also speaks to the variable practice of prescribing rescue medications to patients and families. Mental health represents diagnosing illness, conditions, referral for care, timing, and the provision of care. And quality refers to following recommended screening, prescribing practices, and follow-up. Support includes financial, that represents safe housing, social, that represents isolation, trauma, supports with trauma themselves, distrust, and the burden placed on individuals providing support. Care coordination refers to missed opportunities, lack of follow-up during transitions, care management, and treatment alternatives such as social programs. Educational refers to missing education and counseling, absence of risk assessments, and providers being unaware of the substance use relates to lack of education and counseling for patients and their families. Providers lack skill in assessing the patient's risk, and as a result, we're often unaware of the patient's substance use. Policy includes the legal system, which represents the burden of rules grief and shame with being in the legal system, family separation, unmet needs with practices like jails, with places like jails, and a lack of skill among police and corrections officers relates to the stress caused by the requirements of community service and group sessions. The lack of childcare and transportation were frequently noted to contribute to further punishment. And there were also instances when mothers and their children were separated, and this was viewed as a trigger for relapse. State refers to the fear of the legal system. Think of not showing up or disclosing based on that fear. And insurance refers to the coverage requirements. So here's some examples of recommendations for the themes of educational support, access to substance use resources and treatment, legal system requirements. So educational support recommendation was that providers should educate the patients about the increased risk of overdose postpartum and when changing treatment at the time of discharge or change of therapy, for example. And again, we're focusing on who should do what when. And we did, through this process, learn that the clarity of the recommendations was not always adequate in order for the recommendation to be actualized. And so to hear a little bit more about that, I'm going to turn it over to Ellie Knoll, who's going to talk about the community input.
Thank you, Katie. So we convened the UW Prevention Research Center's Community Advisory Board twice in the spring, again with the purpose to gather input on the feasibility of these recommendations from the maternal mortality review team. So we asked community partners to think about the following questions of, is every critical factor addressed with the recommendation? Is the recommendation feasible? Who should the responsible party be? And could the recommendation be better addressed upstream? So in doing this, the themes that were identified from our community partner participants were trust, community capacity, care coordination, navigation, the justice system, bias, and support. So community partners discussed how their own communities and organizations could implement the existing recommendations or where additional support would be needed to actualize these recommendations as they're currently written. Next slide. So some of the themes in our community partner sessions were also themes that came out of the analysis of the critical factors and recommendations from the maternal mortality review team. But some of them, like trust, were new. So trust included discussions about the importance of shared decision-making, communicating across organizations, and valuing providers with lived experiences. So building and maintaining trust was identified as crucial to successful implementation of any recommendations from the team. And we heard specifics from community partners like trust is established when the individual senses there is communication between agencies on their behalf. Next slide. So other valuable additions from our community partners, examples of emphasizing bias and support. So the impact of bias was a notable part of the discussions with our community partners. Bias showed up in some of the comments and suggestions from community partners and demonstrated that recommendations should consider that every person involved in implementing these recommendations has bias, and also recognizing the gatekeeper role for many of the responsible parties that are identified. So one of our partners shared a quote that the lack of anonymity and changing cultural factors in rural areas might be challenges to implementing recommendations in rural areas. This is a concern for many of the community partners who focus and work in rural areas. In terms of support, the opportunities for supporting pregnant and postpartum people with substance use disorder varied, but included housing, childcare, healthcare services beyond the perinatal period, and the importance of safe transitions. Community partners gave feedback that we need policies and funds to cover a range of supports that add to the stress someone might be experiencing at this critical time. And by engaging community partners, we were able to get a better understanding for the capacity of community organizations, note important overlap between the community and the MMR team discussions, and then also identify some new themes that didn't come up in the existing recommendations or critical factors.
So we want to thank you for participating in our session and encourage all of you to access the Wisconsin Maternal Mortality Review Pregnancy-Associated Overdose Death Report. Either of these websites will get you there. And to close, we did learn that this process does fit into qualitative analysis of surveillance information, such as what you will get from a public health review.